Our medical director, Dr. Becky, sent us this amazing article last month on sickle cell families. And this is the statement from the article that like totally stuck with me. There may be no population of patients whose healthcare and outcomes are more affected by racism than those with sickle cell disease. So I was like loving this. I loved the whole thing. So I sent an email to the author, Dr. Patrick McGann, and said, hey, we're having this amazing care conference like 2 weeks from now. Would you join us? Thinking, no way. Like honestly, I was surprised he even got back to me. And he was like, yeah, sure. And here he is. So I want to thank you so much for being here with us. You are kind of the culmination. We're going to have some fun tonight, but I want to thank you for being here and talking to our parents. This is an issue that we really want to make sure we are part of the solution for.
I'm so happy to be here. Maybe I'm just so excited about this that I couldn't say no. And to be honest, actually, I said yes, what, 3 weeks ago. And then yesterday, I was like, when is that thing? That's next week, right, I think. And it was today, but we're all good. I'm all very prepared, and I'm happy to talk about this topic. I have some slides. See if I can share them. There, let me see if I can do that while also seeing you guys. All right. Good. So thanks so much for the invitation. I'm glad that this is a welcome topic, and I'm sorry to have missed most of the last hour where it sounds like you probably talked about some of these issues as it relates to other health conditions. My name is Pat McGann. I'm a pediatric hematologist at Cincinnati Children's Hospital, which I looked is only about 4 hours down the road from you guys up at your camp. I also, oops, where am I? Am a camp doctor. I've been a camp doctor for many years. First, when I was a trainee fellow, I went to Montana, the place in the bottom right called Camp Make a Dream. And our camp here in Ohio is called Camp Joy. Our hematology oncology camp, we sub-brand as Camp Enjoy It All. And so I love camp. And so a little bit of maybe if you were from a group that wasn't campy, I would have said maybe, but the camp thing got me. So I'm happy to be here. So I have no disclaimers, but my first disclaimer, obviously we're on Zoom, we can see I'm a white male. I'm a white male physician. I have privilege. I don't firsthand know the things that I'll talk about, except that I care for a lot of patients with sickle cell disease and care a lot about them and their outcomes. And so I'm speaking on behalf of my patients, but in no way am claiming to be personally knowledgeable about the direct impact of racism upon personal lives. And I think that's an important thing for all of us to do and say. I heard you say that, maybe I said the word racism. Well, that's really the least of the serious words that ought to be said during these discussions. And so these words have to be said, really. So I apologize if this is redundant to something you may have heard recently, but I'm going to give a little bit of a background for 10 minutes or so about racism and what it is and how it affects health. And then I'll talk specifically about sickle cell disease and how, as you use that quote that we wrote, how sickle cell really is the primary disease, the disease. If you're going to make an impact upon race, sickle cell disease is a place to start. And then some recommendations of what we can do as institution, as camps, as people, as hospitals, as whatever, to be inclusive and to improve these outcomes. So racism is a term that is defined in many ways. This is probably the most well-used definition: a system of structuring opportunities and assigning value based on the social interpretation of how one looks, called race. And this gives unfair advantages to some in our world. These are Black Americans, and unfair advantages to others. These are primarily non-Blacks or whites. And the third bullet point from this definition: it saps the strength of the whole society and is a waste of human resources. It's a pretty broad definition. And as you may have heard, and as I'll talk about in the next couple of slides, there are levels of racism. There's institutional racism, there's personal racism, there's internalized racism, and there's this very nice, this very kind of easy to understand or nice paper that talks about it from the point of view of a gardener. Whoops, here's my slide, sorry. And the gardener, the initial description that explains these photos is the author moved to a home and there were two pots in front of her house. One pot had old dirt and rocks and whatever, and their other pot was empty that she filled with fresh soil and fertilizer and put red seeds in the new pot with all of the new fertilizer and put pink seeds or flowers that would make, or seeds that would make pink flowers in the pot that had kind of old and not very healthy soil. And what happened? The red flowers grew brilliantly and the pink flowers didn't, and this happened year after year. And these things were never changed year after year, and these things just got worse year after year. No one ever changed the underlying initial insult. And in our culture, this is done by historical efforts by our country or within our country to limit opportunities for housing. If you're familiar with the redlining, where people of color were not allowed access to bank loans to purchase homes simply due to their skin color. Limits to their ability to educate themselves, for jobs, for income, for healthcare. All of these things cycle with each other. Oops. Okay. Personally mediated racism is not always intentional. It sounds like maybe this was alluded to in the previous hour. No one's going to say I'm racist, or very few people, I guess. Some people may, but very few people are going to say I'm racist. I would argue that everyone on this call has something inside of them or does things, including myself, that have unintentional bias. And so there's overt discrimination, which still happens for sure, less so than it used to. Explicit bias, where people explicitly will say things or do things that you probably hear in your daily lives. Most commonly and probably under-recognized is implicit bias, where just because of the culture we live in, because of the environment that we grew up in, we have different opinions and treat people differently because of a lot of things, because of their race, because of their gender, because of their religion, because of a lot of different things. We're talking specifically about race, and there's many, many, many examples about implicit bias. Microaggressions. I'm not sure if you're familiar with the term, but these are comments that people will say that aren't really meant to be negative or very racist statements, but are. These can be gender-based, or these could be color-based. I noticed actually in the debate last night, the moderator, who's a woman, but it doesn't really matter, I guess, she at one point slipped and called Kamala Harris by her first name. Do you think she would have ever called Mike Pence by his first name? I doubt it. So that's a microaggression for gender. And these things happen often, where doctors who are women are referred to by their first name, whereas doctors by their men, or men are referred to always by doctor or something like that. These things happen for gender, these things happen for race, these things happen for many reasons that are not necessarily with negative intent, but they are problematic. All of these things, discrimination, explicit, implicit bias, these microaggressions, all lead in direct and very indirect ways on bad outcomes for people, whether it's police brutality, whether it's physicians treating people differently because of their skin color, whether it's people who work in a store following around a person because of their skin color, but not the person who's white. Teachers who treat children differently because of their skin color. All of these things, again, kind of exacerbate the problems that are already so significant. Internalized race, so going back to the gardener analogy, so personally mediated racism is, so at least in this gardener example, the pink flowers on the left, even when they grew, or if they seemed like they were sort of falling off, he would prematurely pull them thinking, oh, you're never going to grow, you're not worth it, versus the red ones on the right sort of were treated differently. So the gardener, he or she treated the plants differently just because of how he felt about them, which was really based in the bad soil, the institutional problems that led to that. Internalized racism, when you're beaten down by a system for so long and your outcomes are negative, sometimes this leads to devaluation or hopelessness or helplessness. If you're never able to move up the social or economic ladder because of the systems that are pitted against you, sometimes you give up, or sometimes you don't want to try anymore. And all of these things are individual wires in this bird cage. So individually, they might not be a big thing, but when you put them all together, it puts you in a cage. You can't get out. And you really need to sort of address each and every one of these to open this cage, to free these birds, to solve the problem. But the problem has been going on for a long time, and causes significant problems for sickle cell patients, if that's what we're talking about today, but for persons of color in our country. So speaking of healthcare, this talk is about sickle cell disease, but this is really can be associated with any health condition of children, of adults, of anyone. And just as one of my favorite images, when we talk about equality and equity, equality is everyone gets the same thing. So in this situation, everybody gets a bike that's this size, but not everybody really can ride the bike. Equity means everyone has different needs, and you need to address those needs in order to have equality. You can't have people riding a bike if you don't address the issues of equity. And the problems with race in this country is there's not equality because there's definitely not equity. And this goes for any health condition, as you'll see in a couple of slides. From healthcare, these differences that I alluded to result in suboptimal access to and quality of healthcare that results in unequal outcomes. So the outcomes are called disparities in healthcare. The inequities are the barriers that are put against patients to not allow them access to what they really need. So a little historical perspective. This is in 1985, the Secretary's Task Force on Black and Minority Health. They recognized that there were 6 causes of death that accounted for more than 80% of mortality in Blacks and other minority groups. That was way higher than whites. And this quote says, it should mark the beginning of the end of the health disparity that has for so long cast a shadow on the otherwise splendid American track record of ever improving health. Seems a bit pie in the sky. The areas, so they created a whole strategy. This was very well thought out. I'm sure it was political, as all things are. And this is what they were going to do. Outreach, patient education, all these things, blah, blah, blah. They were going to fix racism in 1985. How are we doing? This is published in 2013. Don't look in too much detail. Not any better, really. Worse in many situations. So it didn't really come through on what was said. And we know this. Racism is still a problem, as much maybe in the 1960s or 70s, it was more overtly racist, but the effects of racism in this country are no better really now than they were whenever 1985 was 35, 40 years ago. This is a cover of Time from several years ago that, you could strike that and say 2020 for sure. Things haven't really changed. Things have changed where we don't have segregated bathrooms, but the outcomes, especially in healthcare, are no joke and really have not changed and really need to. So I put a couple of examples here of publications really recently. These are all within the last, I don't know, at least the last decade, probably even more recently. Racial disparities in pain management of children with appendicitis. There's nothing black or white about appendicitis, but kids get treated differently. They get different pain medicines if you're white or if you're black. This one, for those of you, I'm sure you guys have kids with brain tumors in your camp. So proton beam irradiation is the fancy irradiation that kids get primarily with brain tumors. There's only several of them in the country. I know we just built one here, and it's, a huge financial enterprise. It's like a big shining thing that the hospital touts. And in this study of people who enrolled children with cancer, mostly brain tumors, who follow protocols, as you know, and you really should treat everyone the same, Black children were 3 times less likely to be referred to get this fancy, special, better type of radiation than white children, just because of their race. Life expectancy is different. Not surprising, given all of the things. These are in adults. Child mortality, pregnancy outcomes, infant mortality, preterm birth, any pregnancy or neonatal outcome is worse if you're Black than if you're white, still now. This one we'll get into. Pain is treated differently. This is very important for sickle cell disease. This is very complicated and very troubling. But the treatment of pain is different. Many people think that people that are Black respond differently to pain or don't have as much pain, or all sorts of really crazy things where I don't know where the ideas come from. And then most recently, very clearly with coronavirus, Blacks are 3 times more likely to die of coronavirus than whites. That's probably even a underestimate, I think. That's the last number I saw. So this is September, October of 2020, in a pandemic where, you know, things should be better, and they are dramatically not. Oops. Sorry, I skipped ahead. This is the article study that mentioned pain management. So this is a study of medical students and residents. These are people who are well-trained, who are going to be doctors or already are doctors. And half of them had at least one belief that Blacks and whites were biologically different. These questions said that Blacks have stronger bones than whites. Blacks have thicker skin. They're less sensitive. Their nerve endings are less sensitive. Their blood clots quicker. Among many other, they age less quickly. There were 7 or 8 different things they asked, and half of these very well-trained people said, yep, there's something biological. Black people are different in these ways than that. And these things also, in a follow-up study, affected how they treat people. So you're gonna give them less pain medicine if their pain endings are different, right? And you know, whether you believe these things outside or answer a survey or not, these are pervasive thoughts in the current 2020 medical community that affect the outcomes for patients, really just because of their skin color. I like this quote. So the Human Genome Project was a very big effort to define our genetic code, and this statement from the director of the NIH, who is the director of that project, says that race and ethnicity are poorly defined terms that are flawed surrogates for environmental and genetic factors and disease causation, blah, 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 blah. Basically, all those articles that I showed you that said that Blacks do differently than whites because of, it's really not biologic. There's nothing telling us that why Black children should be born more prematurely or they should die more of coronavirus than whites. This is because of our societal, all of those barriers that I mentioned. It's not a biologic thing. This quote is nice, or sort of nicely describes the issue too. Race is really a social construct. From Toni Morrison, there is no such thing as race, none. There is just a human race, scientifically and anthropologically. Racism is a construct, a social construct, and it has one social function, racism. So when we talk about sickle cell disease, and everybody knows, or the first thing someone says if you talk to them about sickle cell disease is, oh, that occurs in Black people, right? That's only the first thing people say, is because our society is so racialized. Otherwise, it would be, it's not like you would say, you know, asthma occurs more in people with curly hair than straight hair, or blue eyes versus brown eyes, or whatever. Someone that has a lot of freckles is more likely to get migraines, or, you know, these are just, because we care so much have cared over time for, you know, reasons that are inappropriate, really. It's the only reason why sickle cell disease is known as a Black disease. So most of you, I think, know something about sickle cell disease, but in the very basic terms, it's a genetic condition. It's a problem of red blood cells. It causes anemia. It causes your red blood cells to be stiff. And you see in that little graphic, the blood cells get stuck in blood vessels when they're shaped like those That's sickle, they're banana-shaped red blood cell, and can't deliver oxygen. Red blood cells are supposed to deliver oxygen to every part of your body, and when your blood is sickled, you can't do that very well. And there's all sorts of issues that can happen with sickle cell disease that we'll get into a little bit. If you have sickle cell trait, so you're a carrier of the gene, you need a mom and a dad who are both carriers to have a child with sickle cell disease. If you're a carrier, you're more likely to survive from malaria. So the graph on the right, or the figure on the right and the bottom, shows the continent of Africa, where sickle cell disease is common. The darker the red, the more common Africa is. If I showed the whole world, it really would be primarily rooted in Africa, because the mutation happened to try to protect against malaria. And it did, it does. But because of that, all Americans, really due to slavery and the slave trade, have historical roots in Africa, which is why it's primarily, but not exclusively. There certainly are. It's not a problem of race in America. You know, like we said, race is not a genetic thing, and we are a melting pot here. And there are people who have root genes that come from Africa that have white skin, and we certainly have white sickle cell patients. But most patients are Black. It's a life-threatening disease. You might know it mostly as a painful condition or something causing painful crises, which it does, and we'll talk about, but it affects your body's ability to deliver oxygen to everywhere, from your brain to your toes. You can have painful swelling in your hands and feet on the left. You can have a bad pneumonia called acute chest syndrome. Your spleen is very big and doesn't work very well. Stroke is common. Problems to all of your organs if you don't do something about it. It's a as serious condition as anything that we treat. And it's life-threatening and shortens your quality and quantity of life. Thankfully, these days we have better treatment options, which many patients don't have access to because of racism. But things are getting better, but it is a life-threatening condition for sure. The pain of sickle cell disease, and I'll show you a video with some patient comments in a little bit, is horrible. It's the worst pain you could ever experience. I've seen a lot of patients in sickle cell pain. I have no idea what it feels like. It seems very bad. There are a lot of doctors who judge patients on how much pain they have, or what it feels like, or how much medicine they need, or that they've had enough medicine already. You don't need any more, which really is not appropriate. So you probably know that every state in the US screens for many, many conditions. So if you've had any children, or you have been in a hospital, all babies when they're born get a heel stick, sometimes when their mom's sleeping in the nursery and they don't know what happened. And that drop of blood goes to the lab, and many, many things are tested for, including sickle cell disease. I give a lecture every month to the residents here in Cincinnati. The lecture title is Sickle Cell Disease. And I ask them, hey, what do you think is the most common disease detected on newborn screening in the US? I've given it every month for the last, 5 or 6 years. What's that, 60 or 70 times? And less than half of the time, way less than half of the time, I get a different answer than sickle cell disease. I don't know, maybe thyroidism, maybe something else, cystic fibrosis or something. Because it's considered a disease just of Blacks. It's a condition of the minorities. Well, it's still common enough that it's way more common than any other condition of all other ethnicities. It's the most common thing detected on newborn screening. 1 in 2,000 Americans is affected. There are statistics that cite how common it is among Black Americans. And I try not to use those statistics anymore, because this is really a problem. This is a health problem affecting Americans' children. And the more we talk about incidents and things related to Black and white, the more we're promoting or sort of speaking of the issue. Initially, when they first did newborn screening in the 1980s, they would choose who would get tested for sickle cell based on skin color. So the nurse who was collecting the blood would say, you're Black, I'll test you. You're not Black, I won't test you. I'm not sure, we won't test you, we will test you. And they found that if they did it that way, they would miss 20 or 25% of sickle cell cases. Again, you don't know people's true ethnicity or the color. I mean, you can't tell by the skin color. Again, race is not about genes. And so now all babies, Black or white, or any color, are tested for sickle cell disease. And it still is the most common condition by far detected on newborn screening. A little bit of history only to make a point that this is not a new disease. This is was discovered over 100 years ago when a dental student from Grenada was hospitalized in Chicago, and someone drew the sickle cells that they looked under the microscope and called it sickle cell disease. And then 50 years later, Linus Pauling called it the first molecular disease. So they found the genetic problem that caused sickle cell disease. This was the first time they ever found the actual gene that caused a condition. Won the Nobel Prize. It was really well touted. And the problem, as we'll get to, is 50, 100 years doesn't matter. Nothing really nothing happened despite all of this. You'd think if we've known about it for 100 years, we'd have 100 treatments, right? Or we'd have the cure, or we'd have something to do for it. No. If it happened in people who were not Black, would it? Probably. There's quite a political history to sickle cell disease. In the 1960s, during the highly racialized 1960s, the Black Panther Party did a lot of advocacy and actually testing for sickle cell anemia. You see a couple of these images here. They referred to it as the Black Genocide, citing that the fact that people have known about this disease for 50 years and have done nothing is a way to suppress Black people and kill Black children, essentially, because at this time, mostly kids were dying when they were children because there weren't many treatments available. In 1972, Richard Nixon, again, a political move, but it was good for our patients, signed what was called the Sickle Cell Anemia Control Act. This gave access to research funding and opened big comprehensive centers funded by the government, among other things, started newborn screening really, or the idea of it. And it was a good thing. His quote that I actually just found in preparation for this talk was kind of shocking because I could write this today and it would be accurate. It said, "A targeted disease for concentrated research should be sickle cell anemia. It is a sad and shameful fact that the causes of this disease have been largely neglected through our history. We cannot rewrite this record of neglect, but we can reverse it." It's basically what I wrote in this thing that was alluded to. I wrote that 3 months ago. It's shameful. It's sad and shameful now that this is still a thing. It's horrifying, actually. In the US, there's over 100,000 Americans living with sickle cell disease. I mentioned it was discovered over 100 years ago. Nobel Prize was won for finding the genetic cause. No treatments were available until there's a medicine called hydroxyurea, which was developed actually for something else and kind of serendipitously found to work for sickle cell in the 1980s. It's our primary treatment now and is an excellent medication. And then just last year, there was a few more medicines approved, but there's 4 in total approved for sickle cell disease. That federal funding for comprehensive sickle cell centers that started in 1972 was stopped in 2008. In addition to the living with sickle cell disease, our patients have to navigate life as a Black American, which has many of its own barriers. And trying to do these two things together makes things even worse. This comparison is often made. I am not at all saying anything negative about the serious nature of cystic fibrosis as a disclaimer, but it is a very, very natural comparison. So sickle cell disease, a genetic condition founded in 1910 that affects Black Americans. Cystic fibrosis, a genetic condition founded in about 1960, I think, that affects white Americans. 100,000 people in the US with sickle cell disease, about 30,000 with cystic fibrosis. There's 27 times more funding for research for cystic fibrosis and sickle cell disease. There's 15 FDA approved drugs and counting for cystic fibrosis and 3 very recently for sickle cell disease. And these FDA approved drugs are expensive. They're made by fancy rich drug companies and that pays it forward. So these approved drugs pay into the research funding in what's called the Cystic Fibrosis Foundation. There's 120 comprehensive cystic fibrosis centers. I told you that funding was cut off for sickle cell centers in 2008. There's patient registries to follow outcomes and treatments. There's a million comparisons that can be made, but there's no stark comparison of the privilege of white folks and the detriment or the challenges of Black. There was a quote during the 70s when this Richard Nixon law was, or act was being passed by a senator who said, if this happened to if this disease affected a white congressman or congressman's kid or white Americans, it would have been cured by now. And I don't question for a minute whether that was the case. Gene therapy, which is now becoming a reality, hopefully, for sickle cell disease, is further along for other super rare conditions that affect white folks than blacks. And again, there's a way to wave your hands and explain why, but if you go back to the root of it, we all know why. So talking about patient experiences, we'll go into each one of these a bit carefully. Emergency room is where many of our patients seek care, mostly when they're in pain, like really the worst pain that they've ever felt, more pain than probably any of you have felt in your life, and hopefully you never do. All of these things they all happen every time pretty much when patients go, and you'll hear from patients about how they deal with this. And these lead to poor quality of life because they don't get good care, they don't want to come to the hospital, and bad outcomes, death and other bad outcomes. Drug seeking is a big one. So a sickle cell patient walks in and said, I have the worst pain in my life. I am usually 10 milligrams of morphine is what works for me. And the doctor will say, whoa, your heart rate is fine. You're texting on your phone. 10 milligrams is too much. You don't need that. It doesn't seem like you're in pain. They're not believed often. This has been proven study after study. And especially in the opioid epidemic, they're thought to be drug seeking, or they're wrapped into that opioid crisis thing. And there's been data to show that sickle cell patients don't have any increased overdoses or any of the bad things that happen in this bad opiate crisis. But when they get there, if you say, imagine going to the hospital and saying, I have pain, and the doctor saying, no, you don't. Sorry, it's unacceptable. So there are guidelines from the National Institutes of Health that say if a sickle cell patient comes into your hospital with pain, they should get a pain medicine in 60 minutes. And if they still need more pain, they should get it 30 minutes later. And this study of children, so this is way, way, way worse in adult hospitals, but in pediatric hospitals, less than half received a dose in an hour. And if they needed a second dose, only 15% received it in that time frame. There's a term called Sickler, makes my skin crawl. You shouldn't talk about that asthmatic, that Luke, that whatever the diagnosis is, cystic fibrosis, hemophiliac. Some of these terms are used, but no term is laced with more than the word sickler. Imagine a patient coming into the emergency department. Oh, there's a sickler with pain in room 6. What's behind that statement? A lot. There's been studies showing that patients don't like it, obviously, and doctors, when they say it, have negative connotations to that word. It's derogatory, it's dehumanizing, it reduces the existence of the individual to a mere disease. So don't call anybody by their diagnosis, and certainly don't ever use or let anyone use the word sickler. Goes on and on. They wait longer in the ER. This study was interesting. This looked at patients in the ED who had sickle cell disease, just regular patients who were there for whatever reason, and patients who had a leg fracture, a long bone fracture, probably a leg. And so those were in acute pain. Sickle cell patients waited longer than all of them. And even though they waited 50% longer than the bone fractures, even though they should really be triaged the same, they should have the same wait time. The pain, they're here for pain, and it was different. Why? Well, so all of this leads to fear and mistrust. So 2/3 of patients say they delay going to the ED because of all these things. They're not going to be believed. They're going to be treated poorly. Why would you want to go? 50% of patients report saying they don't think that doctors or nurses in the emergency room care about them. Most patients, when they leave the ER, are not satisfied with the care that they receive. So what do? They avoid care. What happens if you have sickle cell and you avoid care? You die, or something terrible happens. It's not like you'll get over your little cold and be fine. Sickle cell problems, including pain crisis, lead to other serious life-threatening events. And so these things really need to be addressed. All right, let's see if I can switch my screen here. New share. That plane.
There's actually a recent article published that sort of tried to capture what it's like to live with this disease on a daily basis. And 30% of the patients that were studied had pain 95% of days. But they didn't seek care. They sought care for like less than 20% of those days because they know they're probably not going to get the care they need. And the other is that they've learned to cope with a lot of pain on a daily basis. One of the reasons I opened this infusion clinic and that was a sign of addiction. It's not even the verbal communication, it's the nonverbal communication that really gets under my skin because, you know, you get this look and this tone like, okay, you've already had enough medicine, so I'm not giving you any more. Or, you know, you have to have felt something. That's the worst. When I hear, you have to have felt that. You have to, and I'm like, no, if I did, I wouldn't be calling, I wouldn't be buzzing you every 10 minutes telling you. Extra measures of I'll go through extra measures of making sure that, this is weird, but making sure that I'm dressed professionally before I go to the hospital, or not go in like sweats and, you know, in my socks because I don't feel like I'm being taken seriously. It's just a remarkable thing, you know, that I have to call ahead of time and say, so-and-so is coming in and they're a professional whatever, so therefore we're going to believe them. Whereas, you know, this disease causes a lot of disability. And so a lot of my patients are unable to work.
Sorry, I'm trying to figure out how to get back to Zoom here to share. So imagine breaking your leg or falling down the stairs or getting hit by a car and saying, oh man, I gotta go to the ER. I'm gonna go put on my makeup and get dressed in my finest clothes so that someone will take me seriously when you're in the worst pain you've ever had in your life. And that's not a one person's story. I've heard this before. And this happens for, you know, sickle cell patients and others. I mean, I think that, you know, that the pain that sickle cell patients are in, if you've seen it, or even just hearing what it sounds like, it's horrifying to think that patients have to do that just to get taken seriously. So this looks like maybe it projects a little blurry. You may be familiar with what are called social determinants of health. And so sickle cell disease we talked about is a serious condition, regardless of anything. If it happened to white people, it would be a serious condition. Social determinants of health are things that are really basic life things that you have or don't have, and that lead to worse health outcomes. These are things like economic stability, social and community context and support, neighborhood and local environment, access to any or high quality healthcare, access to education. And if you're limited in any of these areas, it's been proven again, similar to the articles I showed earlier, that social determinants of health will affect your risk of anything, heart disease, bad outcomes from surgery, you name it, it happens. And certainly it happens in sickle cell disease. There was a recent study by our fellow and my co-author for that piece, Dr. Power Hayes, that looked at screening all the kids with sickle cell disease for social determinants of health. You see them bullet pointed here. These aren't like access to college education or access to the internet or to Netflix. These are housing, food, employment, childcare, education, utilities, heat, hot water, transportation to the hospital to get your drugs, ability to pay for these medications. So we prescribe it. I can do all I can do as much as I can as a doctor. I know what the best thing to do is for sickle cell disease. If patients can't get to me or they can't pay for the medicines that I prescribe, I'm useless. And so I can't overcome these barriers. I can't change the system. The system needs to change. And so this study showed blue is some people with no needs, and the big gist of this whole thing is most people have needs. Many of them have more than one need. And again, these are major needs, like major life needs. If you don't have one of these, every day of your life is stressful to try to meet that need. And if you have X dollars to support your family and it cost, you know, $5 of gas and $10 to get your medicine at the pharmacy, that money's not going to be spent that way. So there's enough talking. What can we possibly do? And this is kind of what we tried to do in that article, and what I've tried to think a lot about over the last several months especially, but always with my sickle cell patients. So a couple of things that we came up with. So reduce the impact of structural racism on sickle cell patients. And so I think, and I'm trying to work at my hospital here, if my hospital, and as I'm sure your hospital and all institutions over the last several months after these murders of Black Americans have happened at the hands of police, many people are up in arms and a lot of people are talking and committing against racism. I got emails from from Banana Republic or wherever, any place I've ever ordered anything from the internet, they sent an email saying we are against racism. Okay, good. What does that mean? So at our institution, if our institution really wants to step up, or any institution, healthcare institution says, hey, we are against racism, we want to change this. You know who you can change it with pretty clearly in a box is sickle cell patients. There's no group that you can focus on and put money behind and make change. So improve federal funding or any funding. So cystic fibrosis is one example. There's tons of rich white donors. There's tons of rich pharmaceutical companies that make CF drugs that fund a lot of the things. Hemophilia has a lot of funding from different mechanisms. Childhood cancer gets a lot of research money because cute bald kids are cute and people donate money to that. I don't care where the money comes from, frankly, but it needs to come from somewhere, whether it comes from the government or from institutions. It just needs to be better. The comprehensive sickle cell centers that were going on for so long that really provided a lot of support. So by comprehensive, it means access to social workers and to psychology and to community navigators and all these things that help to address the barriers that are in the face of our patients. So I don't know if you are aware, maybe you're aware, US News and World Reports has all sorts of rankings. Hospitals take them seriously. Our hospital will put a flag up whenever we're number 1 or 2 and 3 and whatever it is. And these rankings seem silly, and they are kind of silly, but they drive funding because when you're number 1 or number 2 or number 3, people come to your hospital from wherever, other parts of the world, other parts of the country, and it makes your hospital money. It makes our hospital money, I know. And these metrics are, one example is time to antibiotics for cancer patients when they come to the ER. So if you come to the ER and you have a cancer diagnosis, if you don't get antibiotics within 60 minutes, you get a ding against you for US News and World Reports. And there's lots of efforts, crazy efforts here, frankly, to do this. Sickle cell patients also need antibiotics when they come to the hospital. Are they in that pathway? Nope. Why? Because US News and World Reports doesn't say they don't measure that. They don't measure anything about sickle cell, frankly. So put them in some quality metrics, or have hospital measures where there are dashboards where you say, you need to have this, this, and this. Hydroxyurea, I mentioned, is the best medicine we have for sickle cell. It has changed the lives of patients. 11% of adults and less than 50% of children are prescribed it. Why? Psychosocial support, all sorts of additional support is needed. Like I said, I can only use so much as a physician. Work on institutional racism and, again, focusing on sickle cell disease. So in hospitals, if something happened, like if a patient got an overdose of some medicine, there would be like a CSI investigation of why that happened, with all people digging into every angle of it. If a patient with sickle cell doesn't get his pain medicine in 60 minutes, nobody probably will ever know. If a sickle cell patient gets hospitalized when they could have gone home from the ER, no one ever says anything. These events, these quality events that happen really because of the institutional racism, need to be investigated as seriously. Have patients and advocates on our hospital task forces. We have a lot of these now these days, as everyone does, for racism and justice and equity. And sickle cell patients need a voice. Have specific pathways to treat pain appropriately, and then have accountability. So you can say, hey, you were 48% last year on getting pain medicine to patients. Now you're 90%, good job. Or, hey, you're still 40%, what's going on? Empower patients to talk about this. I've begun to talk about to patients about these issues. And when they talk about it, they have a lot to say. Oh yeah, the nurse the other day said this, or when I was at the hospital, they did this. And these things happen all the time. And I think we need to encourage our patients to speak up. Interpersonal racism needs to be addressed. These are things that might not seem like anything, but they really are. So I was in my clinic, and there there's a patient who was from Ethiopia. I don't even know if this was a sickle cell patient. It was just an example, who had a very complex name. And the nurse essentially said the first syllable of the name and said, "Who's this?" And it, you know, in some, her name was something else, or was shortened to something else. And I said, well, she's from Ethiopia. This is really her name. Might not have meant anything to the nurse who said it, but what's behind that? Why are you saying that? And how does that change how you treat the patient? Or there's so, I mean, there's a million examples of these types of microaggressions or implicit biases that really affect how patients are managed. The kind of secret test I want to do one day is, so if you have a sickle cell patient who is hospitalized with pain, and you have a leukemia patient, a white leukemia patient who's hospitalized with pain, because leukemia can cause pain when you're diagnosed, and the nurse who's taking care of those two patients gets buzzed at the same time. Buzz. You need to go to room 5 to take the sickle cell patient who needs pain, and you need to go to room 12 to see the oncology patient with pain. Where does she go first? I don't know. I mean, I think I do know, but you know, I think these things need to change. People need to be aware. I'm not saying that having implicit bias, everyone has it. I have it. I catch myself all the time, and I just try to be aware of it. But people need to be trained in it. They need to recognize what their biases are. They need feedback when they do things like this, and we can't be embarrassed or ashamed to say something to people when they do things that are not right. We need to not use the word sickler. We need safe places. So our sickle cell team has talked a lot over the last several months about race and racism, and our team is diverse, and these were uncomfortable conversations at first that have become more comfortable over time. But these things need to be talked about. It's not taboo. The more we don't talk about it, the more there's an action. So in summary, sickle cell is not a joke. It's a really serious and life-threatening disease. There's really no population in the country, in the world. I didn't talk about sickle cell outside of the US. That's a whole nother ballgame. And we need to act on this now. And I'm sort of tired and don't want to be guilty myself of talking too much about this. We really need action. Action include the things I mentioned, among other things. I don't want to see statements in 5 or 10 or 20 years that this is still a problem. And it starts small, and hopefully we'll grow from there, but certainly action needs to happen. Thanks. Hope I didn't talk too long. I'm happy to chat or answer questions.
Thank you so much. That's such good information. I know we have some sickle cell parents on here. I know that you've given us a lot of great information to be able to take some action within our organization, but does anyone have any questions?
I just want to say thank you, Dr. McGann. This is Becky Patrius. I'm the medical director here at camp. Can you hear me?
Mm-hmm.
Okay. My video didn't pop up for reasons that are unclear to me, probably screen sharing. In any case, I frankly can't believe that you agreed to come and talk with us. It brings tears to my eyes. I really appreciate it. And I want you to know that we are very committed to making a difference. Truly, your words mattered when I read them first in our medical journal, and we will carry them forward in my practice, certainly in the practice of all the healthcare providers who are listening, and most importantly in our camp. And I want all of the families that have suffered with a child with sickle cell to know that we are committed to continuing to address these inequalities, and we ask your help and graciousness for any past sins, and know that we are committed to do better every single day, and we're developing a plan as we speak. So we'll need your help. Thank you. Thank you, Dr. McGann.
I think that's great. I mean, just reaching out or having this on your agenda is certainly a step. A comment I had, actually, I didn't think about this before. So I'm not sure where your patients exactly get recruited from or come from, but our camp, Enjoy It All, is a cancer and blood disorder camp, and our hematology oncology group is very split. Like, I do hematology and other people do oncology, and there certainly are sickle cell patients that come But again, they're probably not as well represented, or they're not, maybe camp is not advertised as much, or I don't know. So I'm not sure how in your clinical settings where the patients are recruited from, but I would potentially, if you want to make some action, have additional proactive efforts to really try to level the playing field or recruit more sickle cell patients to your camp. Camp experiences, at least for, I mean, for all kids, but for some kids with sickle cell disease who've never had many of these opportunities in their life, are awesome. And we have plenty of campers who came for their whole childhood and, you know, then are junior counselors and never want to leave, and are sad when they finally get kicked out when they're whatever, too old. So I would encourage you to try to find those sickle cell patients and tell them what camp means, and try to get them there, because they really will do great. And the thing that I love about, so our camp, the way we do it is it's half, every patient can bring a sibling. And so it's half patients, half siblings, and diverse. And there's sickle cell patients, and there's white patients with cancer, and there's black patients with cancer, and there's hemophilia, and all of these. And you don't know who's a sibling, who's a patient, who has sickle cell, who has something else. And it's great because nobody knows. And so that's sort of part of the kid's life. They're not labeled by their disease, whether it's cancer or sickle cell disease. They're just having fun at camp, which I think is really awesome.
Dr. McGann, this is Patrick. I'm the camp director, and yeah, we certainly are grateful for the opportunity we have. We work with a lot of the local children's hospitals, you know, DMC, and then we also have some relationships with a couple in Chicago. So we are working to do exactly what you said. But I think we've certainly experienced some of the other challenges of equity, of being able to transport kids. I think Jessica might be able to be a little more accurate, but, you know, out of, I think our highest number of camper applications has been like 129 or something like that for a session. So we serve the population along with some others, but it's primarily just kids with sickle cell disease in one particular session. And but I think our highest enrollment's been like 109, and oftentimes is closer to probably between 90 to 100. And a majority of those kids are coming via bus because they don't have access to get to camp. And that's a huge struggle, especially Chicago. And a majority of our kids actually do come from Chicago as well. I think we probably 50 or so, maybe 60 kids are Chicago out of that 100.
Yeah, I think you need to get creative with these things, right? I mean, it's the challenge, but in order to, again, you need to sort of go outside of the box somehow.
Hi, I'm Siobhan Burgess. I can't see. Okay, here I am. I just want to say my favorite slide, I'm a mom with a child with sickle cell disease, and my favorite slide was your slide that said that you're a white male with privilege. That, I mean, most of the other stuff I already knew. But one of the doctors were talking about some of the civil rights things that are happening right now. And she spoke to the fact that it wasn't just Black and brown people who were marching in regards to George Floyd and Breonna Taylor, but that I think it takes a community, and that community is a rainbow of different people. And if as a privileged white male, if you can so publicly talk about the injustices that happen in our community, specifically our sickle cell community, but also the community that impacts African Americans and other Black people, I think that's one of the key factors there, because for us as parents, it's just sort of like a broken record at times. I have been the parent. I talked about a different thing where, like, I forgot my wedding ring and I was like, oh no, this is gonna be a rougher session for me with my daughter. And if you continue that, and more of your colleagues continue that, I'm really, this session brought, I think that the word that it brought some hope for me, because it wasn't just, crap, I'm gonna cry. As a Black woman, you're not supposed to cry on a Zoom call full of people. That's a rule. But it brought hope. Because when my daughter was 2 months old, I was told just to wait. Things might get better, they could get better. But when you look at an illness that was discovered in 1910 and the first medication wasn't available to the 1980s, so many people waited for 70 years and nothing happened. And we couldn't wait. And I think I'm glad that we're now in a space where we're not waiting anymore. And I appreciate everyone here, but specifically people who don't look like me, who are advocating for this illness. Thank you. I broke my rule.
Thanks for your comment. I don't think I've ever made two people cry in a Zoom call before. So I thought that I've learned to, or actually I was educated really by my Black colleagues that you have to say this. You can't, like, black and white isn't, it's there. I am who I am. And it sort of, I think it's important to say that. And when I try to talk to my patients, there's always that disclaimer, and it's sincere. I mean, I think it's important, and I think it's uncomfortable. Most people don't, and I, am learning to become more comfortable, but I'm cognizant of it. And even when I, give a talk like this or write something like the thing that I wrote, and the co-author that I wrote it with was a Black female, if it matters. I didn't recruit her because she was Black. She's just passionate about this. But I don't want to be the white savior. I'm not, and that's not, but I'm very cognizant that this could be how it's seen, because there's a lot of, white people who say a lot of things and don't necessarily do a lot of things. And I like if we can have this conversation in 5 or 10 years to say, well, we actually did some things, and I think we can.
Well, I know we would love to start partnering with you, because I know that as a mom who feels like these sickle cell women are my sisters now, I want to make sure that we're doing everything we can to support our families and making good decisions for that will help impact the future rather than just sitting and waiting. So. Anyone else have anything? Thank you.
What's your evening entertainment? How do you do Zoom entertainment?
Entertainment. Last night we had Free Daps, which is a freestyle rap group. Tonight we have a singer who, Coach, you gotta help me out here. I'm sorry.
No problem. I'm just gonna pass that on over here and I'll take care of that. No need to worry. We have one of our awesome volunteers, Christina, coming to sing for us. And so she's a student at the University of Michigan School of Music, Theater, and Dance. I think she's also doing a dual degree in kinesiology. And so she's going to be closing it up, wrapping it up with some songs. And part of her intentionality with the songs is creating a story about a caregiver. And so we'll have some narration with that. But yeah, she's fantastic. We've used her before, and love to extend an invitation to you. I know you're a very busy person, but if you want to even just have it on the background to listen to an awesome singer, get a bit of the connection with all of us, that'd be great.
That's good. And my other question, are you guys doing camp this summer? Next summer?
Virtual.
Oh, we didn't do it this summer. We'll have to see. I mean, if we get a big cure for this disease. I think it's hard to see what the future brings right now, but
true story. But
we will be with our campers in some way. We can promise you that. We're not leaving them during this time.
Okay.
So.
I hope everyone votes in a month, please. Thanks.
Yes. Okay. Thank you so much for joining us. We appreciate you.
Sure. Bye.